A very warm welcome to Digital IHRS 2021. I'm Dr. Deep Chandraja. I'm a doctoral fellow at the Australian National University, Canberra. Under the session of cryoablation, we have 4 exciting topics lined up: the pulmonary vein anatomy, cryophysics, challenging situations, and then protecting the clinic now. I'm going to take you through the pulmonary vein anatomy, the normal, the variants, and then the difficulties during the ablation procedure. What is the typical anatomy of the pulmonary vein? 2 on the left side, 2 pulmonary veins on the right side, draining into the left atrium through 4 distinct pulmonary vein ostia. Way back in 1966, Nathan and his team gave us the insight that myocardial sleeves from the left atrium extend well into the pulmonary veins. Then came a series of investigations. Then in 1998, Michel Hazagar, with a seminal paper, told us that these pulmonary vein muscle fibers, which are in fact the triggers for paroxysms of atrial fibrillation, and they can be ablated. These pulmonary vein triggers need to be isolated from the left atrium. They are never to be ablated from within the pulmonary vein. Irrespective of whatever technology that we might use, thermal or non-thermal, it is important to stay well beyond the veno-atrial junction, well within the left atrium, what we call as an antral ablation. In addition, left atrial anatomy is a lot more challenging with its subepicardial muscle fibers, the Bachmann's bundle, septopulmonary, and the vein of Marshall connection. When we face a patient with a typical pulmonary vein anatomy, what I would describe as that shown in this figure: a CT scan of a patient with 4 distinct pulmonary vein ostia, good sized pulmonary vein ostia, good enough for cryoablation. I look at the shape of the arc, which is good here, the shape of the carina, which is a wide angle carina, which would give a lot more catheter stability for me during the cryoablation procedure. The takeoff of the pulmonary veins in the course of the pulmonary veins is also optimal here. And then the shape of the iliac ridge is also looked at. For me, this is a very good pulmonary vein anatomy for anyone who wants to start off with their cryoablation career. The shape of the pulmonary vein ostia, I must emphasize, are more often enlarged superior inferiorly, and they are flat anteroposteriorly. So they are mostly oblong in shape. As shown in this figure, the right and the left pulmonary veins, the ostia are oblong in shape, and the right inferior and the left inferior are more circular in shape. For oblong-shaped ostia, the circumferential balloon to the tissue contact may not be 360 degrees. And hence, you might encounter superior-inferior contrast leaks when you inject the contrast into the vein. And you might need to do certain adjustments like a pull down or a push up so that you can close those leaks. Again, it is very important to appreciate a funnel-shaped ostia. When you inadvertently put the balloon into the pulmonary vein, into such a funnel-shaped os, there is more risk of pulmonary vein stenosis. The size of the pulmonary vein ostia, again, in atrial fibrillation patients, they are not much different among the all 4 pulmonary veins. They're usually around 18 millimeter, more enlarged supro-inferiorly, as I had mentioned earlier. The left common os is usually around 25 millimeter. It could be as large as 30 millimeter as well. We have a 28 mm cryo balloon to ablate the veins, and we do have certain techniques that we can adopt, which I'm sure the upcoming speakers will discuss with you. The attitudinal anatomy of the pulmonary vein is important. The orifice of the left superior pulmonary vein is usually higher than the right superior. It is not surprising that we encounter a lot of left superior pulmonary veins just take off the left atrial roof. The trunk of the pulmonary veins, as shown on the right side of the picture, the superior pulmonary veins tend to course themselves forward and upwards. And the left inferior and the right inferior move backwards and downwards. But then if the pulmonary vein ostia is at an abnormal location, like in this particular CT scan, and the left upper and the lower are sharing a common arch, the takeoff of the left superior pulmonary vein comes at a weird angle, more of an acute angle here. It is important to appreciate this because this might interfere with the coaxiality of the balloon with respect to the long axis of the pulmonary vein. Again, in the right inferior, you can see it is almost at 90 degrees to the left atrial posterior wall. Among all the pulmonary veins, with the cryoballoon catheter, it's always difficult to ablate the right-sided pulmonary vein, specifically the right inferior pulmonary vein. It has got more so to do with the site of the transeptal puncture. Hence, we always recommend a low and an anterior puncture on the fossa ovalis so that you can arch your sheath and catheters clockwise and wrap up the septum and get into the pulmonary veins. Like in this example, the right inferior pulmonary vein taking off perpendicular to the left atrial posterior wall, and our puncture was also a little closer to the pulmonary veins. Hence, we had to do this approach, the hockey stick up maneuver. There are again alternative maneuvers like the pull down and a few more maneuvers that you can adopt so as to achieve coaxiality with these pulmonary veins which take off at different angles. The carina is the region that is sandwiched between the upper and the lower pulmonary vein. As you can see on the left side, a wide carina offers better stability for the balloon catheter than a narrow carina as you see on the right side. A narrow carina, you might not be having a good stability of the balloons at the carina, and it is directly correlated with lesser acute success rates and more number of reconnections. The shape of the LA ridge is again important to appreciate. The LA ridge is a structure that runs superiorly to inferiorly across the left atrium, separates the left atrial appendage anteriorly from the pulmonary veins posterior. These ridges are usually very thick in the superior regions and tend to taper down as they move inferior. Most importantly, the LA ridge harbors the vein of Marshall. And if the ridge was as sharp as shown here in this particular picture, it would act like a flap. And if it were a flap, the balloon to the tissue contact is not firm. And if it is not firm, it can not result in a transmural lesion. Hence, it is important to appreciate the sharpness of the LA ridge, in which case you might use maneuvers like a more counterclockwise torque on the balloon catheter so as to achieve better contact with the LA ridge. The variation in anatomy of the pulmonary veins is usually 38%, around 40%. The most common variation is the left common arch, and then the right supernumerary pulmonary veins. Let me show you a few examples. In this particular case, the right upper and the middle have distinct ostia, but the left upper and middle have a common arch. And in this particular patient, both the right and the left-sided veins have a common arch. Whenever you have a common arch, what we do is sequential segmental ablations. it goes around in a clockwise fashion, and the north, east, south, west, and do 4 different freezes so as to isolate these pulmonary veins with a common off. This is an example of a right middle pulmonary vein. In this example, the right middle pulmonary vein is small. In this patient, we did a proximal seal ablation of the right upper and the lower, which was good enough to isolate the right middle. But then at times, you might need to get into the right middle pulmonary vein to isolate it, like in this patient on the right side. We did a virtual CT on that particular patient. He had a sort of a short common os between the right upper and the middle, which was good enough for us to do a common or a segmental ablation of the right upper and the middle. So first we place the achieve catheter in the right upper, do the freeze, and perform a second freeze while in the right middle. This is an example of a challenging pulmonary vein anatomy. Let me go through the red flags. First of all, is the bulge on the posterior wall. Such a big bulge on the posterior wall would mean poor contact of the balloon with the tissue. Hence, I know that I'll have to give a more clockwise torque on the balloon shaft so as to achieve contact with this large posterior wall. Again, angulation of the left superior and the left inferior are so acute here. I might need to push the achieve catheter deep inside so as to achieve stability. And then I might be ready to move the balloon shaft clock and counterclock so as to achieve coaxiality with the long axis. Again, the right inferior branches off at a perpendicular angle. And more importantly, in this particular patient, the esophagus was right there on the right side. This patient did have a successful cryoablation of all 4 pulmonary veins. But then this is an example. This is an example of unfavorable pulmonary vein anatomy. We describe this as conjoined inferior pulmonary veins coming off with a common ostia from the posterior wall and also at acute angles. The left superior is good there, but then the right superior has such a big common os. I wouldn't say common os, but a big, large os. So you might need to perform a sequential ablation. So there are multiple challenges in this particular pulmonary vein anatomy, and I would be skeptical to take this patient for a cryoablation straight away. This particular patient, in fact, had a conventional RFA with a box lesion set. Again, in experienced hands, nothing is impossible, but for centers in the early part of their learning curve, I think you should learn to choose your patients before subjecting them to cryoablation. It is important to also understand that the right phrenic nerve courses anteriorly to the right superior and the inferior, hence important to monitor the diaphragmatic contractions during ablation of both the superior and the inferior right pulmonary vein. The esophagus, so closely spaced, are placed behind the left atrium. It's like next door. And it's very important to use an esophageal temperature probe, as we always do, so as to monitor the temperatures even during cryoablation procedures. Ladies and gentlemen, let me conclude here. I'm highlighting the importance of pre-procedure imaging, be it a CT scan or an MRI, or even as simple as an echocardiogram, that is going to give you a lot of insights of the anatomical characteristics of the pulmonary vein. You can look at the drainage of the pulmonary vein. Are we dealing with the left superior vena cava? Hope we have ruled out partial anomalous Smith-Arp syndromes and things like that. The number of pulmonary veins, size and shape of the os and the trunk, course of the trunk, the shape of the carina, and the sharpness of the leverage is what we look at. Thanks a lot for all of you for your patient listening. Wish you all a safe and a happy 2022. See you all next year.